Hello, and welcome to the Path to Parenthood for LGBTQ plus couples. I'm Veronica Montgomery, and I'm the Clinic and Patient Liaison Consultant here at the Fertility Hub. If you're not familiar with the Fertility Hub, we're a publishing platform that brings healthcare providers in assisted reproduction together with intended parents together under one umbrella. It's a free resource and there's lots of information on the site, so please do have a look at it. That's at www.thefertilityhub.com. As we've just celebrated Pride Month throughout June, we wanted to host a special series of seminars for LGBTQ plus couples to map out the path to parenthood. We had originally intended for this to be a one-day seminar, but once we delved deeper into the complex road for LGBTQ plus intended parents, we decided to split this into 4 parts. So today we are starting with a presentation from Dr. Elizabeth Barbieri, who's a fertility specialist at ORM Fertility in Oregon in the USA. Her presentation will focus on egg-seek sperm for those couples who need to source donor sperm in order to conceive. On Thursday, the 9th of July, we'll see a presentation from Carrie Flamer-Powell, who's going to talk about surrogacy. She started up All Family Surrogacy after being a surrogate herself, and we'll look at both the fertility element, the sourcing a surrogate, and the legal requirements. On July 16th, we'll look at the difference between IUI and IVF with a presentation from Dr. Park at San Diego Fertility. And the final presentation will be on July 23rd when we look at sourcing donor eggs. Some questions, so just a bit of housekeeping now. Some questions have already been sent in. There is a live chat enabled on this broadcast, so please feel free to ask questions throughout Dr. Barbieri's presentation, and I'll do my best to answer you. Any questions that we don't get around to or I feel is beyond my knowledge, then I will ensure that Dr. Barbieri follows up with you after the presentation. So without further ado, I'm now going to turn my camera off because I'm going to be like this, hopefully answering all of your questions, and we shall listen to Dr. Barbieri's presentation.
Hello, my name is Dr. Elizabeth Barbieri. Thank you so much for spending this lovely summer night attending our webinar. So this webinar is focused on those individuals who have eggs and would like to grow their family. Specifically, you would need sperm. So what are the choices we have and how can we help you in this process? A little bit about me, sorry, my colleague's name got inserted in there, but I'm a reproductive endocrinologist. That means I'm a fertility specialist who focuses on helping individuals grow their families. I trained on the East Coast and then relocated to Portland back in 2009 when I moved out here specifically for this job and have been here ever since. Who is ORM Fertility? We are a group of physicians, nurses, embryologists, genetic counselors, psychologists, integrative medicine specialists, and support staff who have dedicated our careers to helping individuals and couples grow their families. We were originally founded in 1989 by Dr. Rob Machiri. We're one of the largest IVF programs in the United States, located in Portland, Oregon. Our downtown office, which was featured in that previous slide, is located, as you can see on this map, is located in the ORM downtown at Southwest 15th. We also have 2 other locations, our West Side office, which is near St. Vincent's, and then our South Side office, which is closer to Tykard. Patients can be seen at any and all locations. The more advanced embryology procedures, such as egg retrievals and embryo transfers, are only done at the downtown office. One of the areas that we're most excited about is our LGBTQ families and single parents, and we have had the pleasure of working with these individuals for throughout over 40 countries. So when we think about if you have eggs, how can we help you grow your family? And there are many options to consider. Simplest one is doing intrauterine insemination. Slightly more complex is in vitro fertilization. This can be done with an individual's own egg and their own uterus are what we refer to as reciprocal IVF, which is one partner's eggs to be transferred into the other partner's uterus or vice versa. Donor egg IVF, gestational surrogacy, where your egg can be extracted and then transferred into a surrogate to carry the pregnancy for you, as well as embryo donation. So to understand how these treatments work, we like to take a step back to 8th grade biology and talk about what do you need for spontaneous conception to occur in the first place. And for spontaneous conception to occur, it's a complicated conversation between our brains, our ovaries, our uterus, and then having sperm appear at the appropriate time. So it starts with your brain, which sends a signal called FSH to your ovary. In the setting of a menstrual cycle, at the beginning of the cycle, the ovaries recruit a group of eggs to develop. And then through this hormonal stimulation of FSH, only one egg is selected. That one egg continues to grow and then ovulates. That one egg that had been ovulated gets picked up by the fallopian tube, at which point sperm would then be introduced, and the sperm swim through the uterine cavity down the fallopian tube to meet the egg where fertilization occurs. That resultant embryo then travels back through the uterus to implant. Right? Easy, not so much. So when you think about how to get started on this journey, we want to do whatever we can to help you be your healthiest self, to understand your menstrual cycle, knowing about ovulation so that then inseminations, if that's the process, will be timed correctly, and then reviewing the different treatment options you can consider. So when we think about preconception health, prior to getting pregnant, what can we do to optimize your body and your chances of successfully conceiving? Some of them will seem simple. If you smoke, stop. Everyone thinks about smoking causing lung cancer. Well, smoking also kills your eggs, and women who smoke tobacco will go through menopause 4 years earlier than women who don't smoke because cigarette smoking can kill your eggs. Vaping's bad too. Marijuana, even though now it's legal, is also not helpful for egg production and for pregnancy. If possible, maintain a healthy weight. We use BMI as a marker. We know it's not ideal by any means, but try to have an appropriate healthy height and weight. Exercise when you can. Eat a balanced diet. Limit your caffeine intake. You don't have to stop drinking coffee, for those of you who love coffee like me, but we recommend limiting it to 12 ounces a day. There have been some studies that suggest drinking more than 250 to 300 milligrams of caffeine, which is about 1 12-ounce cup of coffee, has been linked to miscarriages. So you don't have to stop completely, but limit it to 1 cup. Limit alcohol. So when prior to ovulation, so about the first 2 weeks of your menstrual cycle, when there's no way a pregnancy could occur, you can have up to 4 glasses of alcohol per week. After ovulation, there's no safe limit of alcohol because you potentially could be pregnant. If you're not pregnant after treatment and you get your period, have another glass. But so during the safe windows, if you continue to drink alcohol, limit it to 4 drinks a week. We also advocate for taking a prenatal vitamin. This is slightly different than a general multivitamin because a prenatal vitamin specifically has higher levels of folic acid or folate in it. Folic acid is a critical building block for the fetal spine. And in women who have an inadequate amount of folic acid, their fetuses could be at a higher risk for a birth defect called spina bifida. So that's why we advocate switching to a prenatal. If you're on a multivitamin, if you're not on anything, go ahead and start one. There's no magic answer for which prenatal is best. If you're vegan, go to Whole Foods and get a vegan one. If you hate swallowing pills, the gummy ones are also okay. Additionally, there's some specific lab tests that we recommend as part of our preconception testing. These tests are looking at your thyroid function. Maternal thyroid hormone level can cross the placenta and impact fetal brain development. So we like to look at your thyroid hormone level, make sure it's less than 2.5. We look at your vitamin D level. Yes, we have a beautiful sunny day today, and most of our vitamin D levels are going to start to rise, as opposed to in the winter where most of us are quite deficient. Again, vitamin D deficiency has been linked to difficulties getting pregnant. And as most of you may have never tried to get pregnant before, we're not assuming you're infertile. We also want to do whatever we can to optimize your chances of being successful on the first try. So we check vitamin D and then supplement as needed. We check your blood count. We want to make sure you're not anemic as entering into a pregnancy. We look at your blood type. We check immunity to varicella and rubella. And if we find that you are not immune, we would advocate for getting a vaccine to gain that immunity. Varicella is chickenpox, and rubella as part of the MMR. And these two viruses, if contracted in pregnancy, can cross the placenta and cause significant damage to the fetus and possibly lose the pregnancy. So that's why we advocate checking for those. We also recommend a genetic carrier screening test. This test is optional. We never require anyone to do it. But based on the recommendations from the American College of Obstetrics and Gynecologists, all women who are pregnant or all individuals trying to conceive a pregnancy should be offered testing for cystic fibrosis and spinal muscular atrophy. These are the two most common autosomal recessive genes. By autosomal recessive, it means to develop this disease, baby needs to inherit two genes, one from egg and one from sperm. Individually, the person with the egg might have one copy of the gene and not be affected, because if you only have one gene, it's not going to cause the disease. So you might not have any idea you have it. Additionally, these diseases don't run in families, because you may have the gene and you may have inherited from your mother, who may have gotten it from her father, but you don't know that because nobody is expressing the disease. As some of you may be considering using a sperm donor, we want to make sure that you are genetically compatible with your sperm donor. And in a situation where there's a female-female relationship where you both might want to use the same sperm donor, then we want to make sure you're both genetically compatible with this sperm donor. So we offer this genetic test up front before you select your sperm donor, so that we can do help you find the right donor to give you the best chance of having a healthy baby. So that's your preconception health. Then when we think down to the nitty-gritty of your fertility biology, we think about your eggs. And when we think about the eggs, there's two things we're considering. One, are you ovulating or releasing the egg? And then number two, how good is the egg you're releasing? So the biggest question we get from patients is, well, how do I even know if I'm ovulating? And it's easy to say, are your periods regular? Do you get one every month? And they say yes. And we say, great, you're ovulating. How do we know that? Because the egg develops estrogen, which prepares your uterine lining. And then after you ovulate, it makes progesterone. And if you are not pregnant, that drop in progesterone from the egg causes you to shed your lining. If your periods are not regular, meaning you're getting them every 2 weeks and then every 4 months, not a variation of just a few days, then you may not be ovulating. And there's different ways that we can investigate that. The most common reasons that women may not ovulate include endocrine disorders such as thyroid dysfunction, elevated prolactin, polycystic ovarian syndrome, early menopause. So how do we test for ovulation if there's some concern that you might not be doing it? And then this is when patients come in and they have their charts where they've been tracking their temperature for months. And that's not the most helpful, because a temperature spike only shows up after you've ovulated. It doesn't help us identify better when it might be occurring. And the temperatures are also inaccurate. So the easiest way to figure out if you're ovulating and when that's happening is to use an ovulation predictor kit. It's an over-the-counter pee on the stick test that you check every day during mid-cycle. And when the test turns positive, that's your window of ovulation. Sometimes patients will say, my periods are every 28 days. I keep using those ovulation kits. I never get a positive. I must not be ovulating. No, the kit's not working for you. A more scientific way to confirm ovulation is to look at your progesterone level in the second half of your cycle. Progesterone levels greater than 3 are consistent with signs of ovulation. Again, sometimes patients will say, oh, well, I'm not ovulating because my progesterone level wasn't very good. It was 4 or 7. My doctor said it had to be greater than 10. That's a complete misnomer. Progesterone greater than 3 equals ovulation. It doesn't tell you if it's good ovulation or a bad ovulation. You can't quantify that. It just confirms that you have ovulated. So, as I emphasized, it's not you, it's the kid. The second factor related to eggs, if we talked about am I releasing an egg or not, and then if I am releasing an egg, how healthy is the egg I'm producing? And this term about egg health is called ovarian reserve. And it means your egg quality and your egg quantity, so your overall reproductive potential per your age. And the way we assess for this is a variety of tests, and we look at the results of all of these tests to paint the picture. So the tests include a blood test called an anti-Müllerian hormone level, or AMH. This hormone is secreted by all the eggs you have in your ovaries that your body will use up between now and when you go through menopause. So if your AMH level is high, we can infer that you should have a lot of eggs. If your AMH level is low, we can infer that you might not have as many eggs as other women your same age. It's really important to look at AMH per age, because what's high or low for one woman may not be the same thing as what's high or low for someone else with eggs based on their age. Additionally, we look at a blood test called FSH and estrogen. This is done between days 1, 2, and 3 of your period. That's that time in your cycle where your hormone levels, estrogen and progesterone made by your ovaries are low. So your brain has to send that signal FSH to get your eggs to grow. And our brains don't want to have to work really hard. We just want to sprinkle our eggs with FSH and bam, expect them to respond. So when we look at your FSH, we want this level to be low. If your FSH is high, it implies that your brain is working really, really, really hard to coax your egg to respond. So a high FSH is a bad sign because it makes us concerned that your eggs might not be as healthy as we wanted them to be. And then we also do a vaginal ultrasound during the same window of time, days 1, 2, and 3. And as the picture depicted on the screen shows that gray area with that circle and those little black circles on the inside, those small black circles represent follicles. That's the fluid-filled structure inside your ovary. Each follicle has an egg inside of it. The egg is microscopic and we cannot visualize it with the naked eye, but we can look at the follicles as a proxy for the egg. So we do a vaginal ultrasound to identify how many small eggs are in your ovary in a given month. And then is this appropriate for your age or is it lower than what we would have expected? And how does that picture fit into the blood test that we have done? The reason ovarian reserve is important is that it allows us to better understand and counsel you on the chances of you conceiving per 1 month of trying based on your age compared to other women your same age. And as we know, per 1 month of trying, our chances are best at our younger years, and then over time will start to decrease because of the impact of age on chances of finding healthy eggs. So then switching gears, the other test that's important is a test looking at anatomy. This specifically examines the uterus and the fallopian tubes. The easiest way to test for this is a test called the hysterosalpingogram, which we often abbreviate as HSG. It's also known as the dye test. It's a test done prior to ovulation, so usually between days 6 and 12 of your cycle, where a small amount of dye is placed into the cervix, and then a picture is taken. And as you can see on this radiograph, there's this white triangle. That's the inside of the uterine cavity. That's a normal size and shape. There's no black spots in there that might indicate a fibroid or a polyp, some sort of benign growth, non-cancerous, non-bad, but in the way of where an embryo would implant. Additionally, you can then see these little shoestrings kind of off to the side on either side, and then it pulls into this group of fluid. That's the fallopian tubes on either side, and it shows that they're both open as the dye spills through, and then in the pelvis. So this is the best non-invasive test that we would do to look at your anatomy and ensure that there's no challenges to conceiving. So when we think about, okay, we talked about eggs, we've talked about anatomy, but we also need sperm. And so what are the ways we can actually help you utilize this sperm to grow your family? They break down into 2 main categories. The first is intrauterine insemination, or IUI, and this can be done with or without medication, and we'll talk through that. And then the second one is IVF, or in vitro fertilization. This is a more complex process involving medications and extracting eggs and fertilizing them with the sperm in the lab to create embryos and then transfer those embryos into a uterus. And this can be done, as we mentioned earlier, own eggs, own uterus, own eggs, partner's uterus, own eggs, surrogate uterus, or donor egg, or any combination thereof. And then for those individuals who are curious about their fertility or have some concerns but aren't yet ready to become a parent with donor sperm, there's also the option of freezing your eggs, which would give you the opportunity to potentially use these eggs at a later date when you're perhaps older, with the same success rate as when you froze your eggs at a younger time. So when we think about IUI, we can do it with natural, as I mentioned, in a natural cycle or with medications. In a natural cycle, you would simply use that ovulation predictor kit and monitor for ovulation. Call us when you get that positive surge and come in the next day and we would do the insemination. For some patients where that doesn't work or who want to do something a little bit more complex, we can add in a simple medication. It's an oral medicine called Clomid or letrozole, also known as Femara. These are 2 oral medications that you take for 5 days, days 3 through 7 of your cycle on average. They work by increasing your brain's production of FSH, so that instead of growing 1 egg on your own, you would grow 2 eggs and only throw out the remainder. By increasing your egg number from 1 to 2, this could increase the chance of success of finding one good egg. There is a small chance that you would end up with twins or more multiples than that, and we monitor your cycles carefully. With Clomid or letrozole, or as I mentioned, in the natural cycle, the way you get the sperm is by doing an intrauterine insemination or an IUI. This feels very similar to a pap smear and takes about 2 minutes. Very not romantic. We have you come into the office. We identify the donor sperm that you had selected. We place a speculum. We take a tiny catheter, a tiny straw, and we actually place it through the cervix so that the catheter gets into the uterus, and that's where you deposit the sperm. With frozen donor sperm, we want the final sample to be around 10 million moving sperm, and we'll always let you know what that number is. After we do the insemination, you rest for about 5 minutes, and then you're free to go, and we would check your pregnancy test in about 2 weeks. If you're not pregnant, you'll get your period, and then we can start again. We only advocate using 1 vial of donor sperm per insemination. There's no increased chance of success if you do inseminations back to back over the course of 2 days. It just costs a lot more money. Okay. More complex treatment with donor sperm is IVF, or in vitro fertilization. IVF is a process that has been around for over 40 years. The first baby conceived from IVF is Louise Brown. She was born in 1978. She is healthy and has gone on to have her own children. So I tell patients, IVF has been around for over 40 years. IVF babies are healthy up until age 42. Next year, it'll be up until age 43. Since she's our oldest patient, she's kind of the barometer by which things are set. In the United States, in tracking cycles, as most recent as 2017, where we have the most recent data, over 300,000 IVF cycles have been performed annually, and over 8 million babies have been conceived from IVF worldwide. So by and large, we think it's a safe, viable treatment option. How does IVF work? Well, going back to that concept of recruiting and a group of eggs every month, of which your body will select 1 to ovulate, and you're going to dispose of the rest. And then sometimes using that medicine Clomid to help you ovulate 2 and still dispose of the rest. The goal of IVF is to use injectable medications to get all of the eggs in your ovaries in that 1 month to grow. So by getting more eggs, we have a much better chance of finding the right egg to give you the best chance of getting pregnant. The way we get those eggs to grow is to use injectable medications. These medicines are FSH and LH. Again, those are the same hormones that your brain is naturally sending to your ovary to stimulate the growth of 1 egg. So we supplement you with additional hormones to rescue those other 15 eggs and get them all to grow. We then monitor you with vaginal ultrasounds serially through this 2-week process to ensure that your eggs are growing appropriately, and this allows us to adjust your medications accordingly and then determine when to extract the eggs. So on the slide, it depicts an ultrasound with several small eggs, and then over time, all of those little black circles, again, those follicles, which are proxy for the eggs, all develop into these large black circles, which tell us that the eggs are close to being mature to be removed. Once the eggs are ready, again, this occurs about after 8 to 12 days of the medication, so almost 2 weeks of taking those injections and monitoring, we do a very simple procedure in our office to extract the eggs. You receive IV anesthesia, so you fall asleep and you would have no pain during this process because you're nice and asleep. Once you're asleep, we use a vaginal ultrasound. We attach a needle. The needle goes through the vaginal wall directly into the ovary to extract the fluid and the egg with it. That fluid is then analyzed by our embryology team to make sure that we've gotten all of the eggs. This procedure takes about 30 minutes. And then when you wake up and you're no longer groggy from your anesthesia, we would say, great news, we got 17 eggs or 10 eggs or however many eggs you were hoping to get from that one procedure. If you are not proceeding with pregnancy that month, for example, if you're freezing eggs or if you're creating embryos to do genetic testing, you will then get your period about 10 days to 2 weeks after this procedure, at which point your body has reset and is back to normal. And in that next cycle, you recruit a whole new group of eggs. So by extracting your eggs from this one cycle, we're not stealing eggs from your future. It's not going to put you into menopause earlier. It's not going to compromise future fertility. Again, it's this concept of rescuing cells your body was otherwise going to dispose of. So once we have the fluid, we look at our embryology team looks under the microscope to find the eggs. This is what beautiful eggs look like. Once we have those eggs, we fertilize those eggs with donor sperm. and especially when we're using frozen sperm. We would do a procedure called intracytoplasmic sperm injection, which is a fancy term for saying we are going to, under the microscope, select the best looking single sperm and inject it into one egg. And so each egg will be fertilized individually by a single sperm. And then about 18 hours later, we would look under the microscope to see the picture on day 1 to make sure that the egg had successfully fertilized, and we contact you with that information. And then that embryo would be developed through day 5. Again, that is mimicking what happens in spontaneous conceptions, where if you had done an insemination, your fallopian tube would have picked up the egg, the sperm would travel through the fallopian tube to meet the egg and fertilize, that'd be day 1, in the fallopian tube. And then as a result, that embryo needs to grow as it travels back over 5 days to the blastocyst stage before it drops into the uterus. With IVF, we're recreating that process in our lab. After 5 days, you have options. One option would be to do what's called a fresh embryo transfer, meaning that this is the period of time where your uterus is ready for implantation. So you or your partner or your surrogate would come in for an embryo transfer, and we look under the microscope and pick which embryos look the best at that time. So they're not frozen, they're fresh. And that's the ones we transfer, and then we'd freeze the remaining. Alternatively, we can do what's called pre-implantation genetic testing for aneuploidy, meaning chromosome abnormality, and about 80% of our patients choose this option. What does this mean? Well, as we know that the older we get, the higher chance we have of having chromosomally abnormal eggs, therefore abnormal embryos. Even though we look under the microscope and all of the embryos look good, not all of them are chromosomally normal. And we don't want to waste your time or cause extra heartache by transferring embryos that are only going to lead to miscarriage or not work. We'd rather have a better chance of finding the right embryo to give you the highest chance of getting pregnant on the first try. So we can do this testing. This testing means that we biopsy or sample a couple of cells from the outside of the embryo. That's called the trophectoderm. Those are the cells that will give rise to the placenta. So we can very safely remove 3 to 5 to 10 cells from the outside of the embryo, not touching the inner cell mass, which is where the baby making cells. We can then freeze the embryo in our lab and send those cells off to be analyzed as a representative for the entire embryo. And what we're looking for is chromosomes, meaning does the embryo have 46 chromosomes, or is the embryo missing a chromosome or have an extra chromosome, which might lead to a miscarriage or not implanting. And then we can select those embryos that have been frozen once we get our results back, the ones that have 46 chromosomes, to be the ones for transfer, as they would give you the highest chance of successfully conceiving. When we look at our data related to frozen tested embryos that have been transferred, the likelihood of successfully conceiving a pregnancy, the green bars represent fresh embryos, meaning we look at the 7 embryos you've created, they all look good, we pick 1 or 2 and transfer it. Compared to the purple, which is you had 7 embryos, they all look good, we tested them, we discovered of the 7, only 4 had 46 chromosomes, and the other 3 were missing chromosomes, meaning they wouldn't even work. So now the pink bar represents what's the likelihood of conceiving a pregnancy if we transfer one of the embryos from that group of 4 that have been tested. And obviously it's significantly higher. Overall, the more complex the treatment is, the more we can control the variables and the higher the pregnancy success rate is. That being said, a lot of my patients who've never tried to conceive a pregnancy in the past are not infertile, and the simplest treatment, which is natural cycle insemination, might be the best, and many get pregnant on their first few attempts of trying. This graph is looking at success rates over based on age and based on treatment intervention. So I know the IUI is a little bit disappointing that it's low, but I think the important thing to remember is if you've never tried to conceive a pregnancy, we're going to assume you're fertile, and ideally you get pregnant pretty quickly. So that wraps up this presentation. I hope that was informative. If anyone has any questions, please do not hesitate posting them on the Q&A, and we can answer them. Alternatively, if you'd like to talk in more detail about your specific scenario or potentially ways we can help you, don't hesitate to reach out to us to schedule a one-on-one consultation. Given COVID, we're doing all of this through telemedicine, so over the phone or through Zoom or Skype, and we'd be happy to talk to you in detail. Thanks so much.
Thank you, Dr. Barbieri. I think you have got a couple of questions coming through there. I just wanted to bring up my screen now to show, let's take it back to me for a sec. I just wanted to bring up the slide with my email address on, which seems to have now disappeared for me. Here somewhere. Okay, got it now. Okay, so that's got my email address there, veronica@fertilityhub.com. We'll just see what Dr. Barbieri's got. We just want to make a note of that. As I say, it's confidential, and I'll ensure that your questions are passed on if they don't get answered now.
All right. We have our first question. Thank you for being brave and posting it. The question is, does ORM offer all the pre-screening and testing before an IUI? Yes, we do. We do not require any of it, but we offer all of it. So if you were to schedule a new patient consult, we would talk about your history, your age, what factors may be that may affect your ability to get pregnant or not get pregnant, and then what the options are. What I typically tell my patients who are considering using donor sperm for IUI is that I would recommend the preconception testing, so that panel of blood work, looking at thyroid and vitamin D and rubella and varicella. And we are happy to draw it here if you know that you have a better chance of getting it covered by your insurance. For example, if you have Kaiser insurance, which we can't accept here, Kaiser can only go to Kaiser, then we're happy to give you a list of those blood tests to have your Kaiser doctor order it. We also recommend the semaphore genetic carrier screening, but again, none of this is required. If you did those two tests and your plan was to then move forward with natural cycle inseminations, we would do that. If you said, well, I'm 37, I don't want to waste time on donors and money on donor sperm. If there could potentially be a problem, I want to do the ovarian reserve testing to look at my egg health. We do that here in-house as well. The only test that we refer out to is the HSG, the dye test. We work with Dr. Amy Thurman, who's a fabulous radiologist in Lake Oswego. She does over 1,000 of these tests a year, so she's truly an expert in it. She knows her way around speculum. And so we would send you to her office for that particular test, but everything else we do here at ORM. Great question. Any other questions?
Yeah, I think there's one more.
How far in advance should you schedule these tests before trying to conceive? Another good question. I would say 3 months. If you do it a year in advance, they're going to be invalid and the year will go by and then we're going to want to repeat the tests. So I would advocate for 3 months, because if we discover that your vitamin D is low, it gives you time to get supplementation to improve it. The genetic carrier screening test takes at least 2 weeks to come back. And then once you get those test results back, then you would look at sperm donors. And then our genetic counselor would weigh in about if you're compatible with the sperm donor or not. So that process, if it takes 2 weeks to get this test back and then another 2 weeks to fine tune your sperm selection, and then a week after that for our genetic counselor to weigh in on it, would end up being 5 weeks. So I think 3 months in advance is reasonable if you know that you have a set date of when you want to start trying to conceive.
Perfect. Thank you very much.
Any other questions? Well, thank you so much for devoting the time to listen to our webinar. If you have any further questions, please do not hesitate to contact us at ORM Fertility or to call and schedule an appointment. We're happy to talk to you individually, address your specific needs, and hopefully help you come up with a plan to help you grow your family. Take care and have a great evening.
Thank you very much. Okay, so as I said, if you want to email me directly, that's fine. I can pass your questions on. My email address is there, veronica@fertilityhub.com. I will stop the live broadcast now, and that disables the live chat. So feel free, if you want to write in comments, I will stay online for another 15 minutes. If you don't feel comfortable with commenting, then please do send us an email. Thank you very much for listening, and I hope you found it informative. And as ever, please feel free to reach out to us at the Fertility Hub. Any questions, anytime. There is a contact form, and do have a look around the website. We are actually in the process of just launching a section of the site dedicated to LGBTQ plus couples, which will have quite a lot of resources there, with a wealth of expertise of people in the field. So thank you very much. Right, let's